Hi guys, welcome back to week 9. This week we are going to continue with endocrine, although this focus will be on diabetes. This entire PowerPoint is primarily focused around diabetes, so just please realize that in terms of your readings, that's what this focus is on. Here we go, guys. Okay, so the first thing I want to talk about is metabolic syndrome. And remember, it's a constellation of risk factors, which includes elevated blood pressure, dyslipidemia, increased fasting glucose, and central obesity. So a lot of these patients, you're going to see that central body fat around their midriff. The metabolic origin is not well understood. However, the thought process is that it's an involvement of insulin resistance that may be the linking factor. Modification to prevent these lifelong risks by recognizing the risk factors and starting lifestyle treatment early is the key to helping manage this or prevent it. Okay, pre-diabetes, which includes impaired glucose tolerance and impaired fasting glucose. Essentially, the values are not quite high enough to be diabetes. Many people who are diagnosed with pre-diabetes will go on to develop diabetes mellitus if not intervened. 88 million people in the US are pre-diabetic, and 1 in 3 are unaware. Diagnostics of pre-diabetics includes an A1C of 5.7% to 6.4%, a fasting blood sugar of 100 to 125, and an OGTT 2-hour blood sugar of 140 to 199. Pre-diabetes, you want to reduce the risk for type 2 diabetes by 58% by doing the following things. Losing 7% of body weight or 15 pounds if you weigh 200 pounds. Exercising moderately, such as brisk walking 30 minutes a day, 5 days a week. And losing even 10 to 15 pounds can make a difference in terms of preventing diabetes. And the FNP can be instrumental and intervene here. So this is really where your role comes into play, by really being proactive in helping this pre-diabetic manage their lifestyle. And just like it says, just simply by losing 15 pounds could make the difference between being diabetic and not. So please just really reinforce the risk factors with your patient and how to reduce the risk by doing just these things. Walking 30 minutes a day, 5 days a week is not that difficult in the scheme of life. You just have to make sure your patient makes it a priority to make it happen. Okay, management of prediabetes. So again, we're talking about lifestyle modification, including diet and physical activity. And this you want to kind of measure over a 3 to 6 month period, because if they've tried their modifications over a 3 to 6 month period and they're not successful, this is when you want to consider beginning medication. Many of the oral anti-diabetics may be used. Typically, metformin is what we start with. It's shown to be effective in metabolic syndrome components, mild to moderate weight loss, lipid profile improvement, and improved fibrolysis. CDC programs across the country exist for prediabetes. So definitely check that out on your CDC website and help encourage your patients to do so as well. Okay, so now we've moved into from pre-diabetes to diabetes. And this, diabetes mellitus is characterized and defined by a syndrome of disordered carbohydrate, fat, and protein metabolism. And this includes hyperglycemia resulting from deficits in insulin secretion, insulin action, or a combination of both. We have pre-diabetic states, and in terms of diabetes type 1 and type 2, these are the most common endocrine disorders. 30.3 million US citizens have this, and up to 7.2 million of them may be unaware. This is why we do our annual physical exams and obviously encourage lab work with them, especially if we're seeing that their BMI is elevated, or if they're overweight at any level, or of course if they have a family history. So here's some facts about diabetes. Chronic hyperglycemia results in damage to the eyes, kidneys, nerves, heart, small and large blood vessels. Okay, very important. Loss of vision, renal failure, loss of a lower extremity, and chronic foot ulcers due to peripheral neuropathy. You get complications that result in significant social, economic, and psychological demands on patients and their families. CV and PVD decrease the immune system functioning, renal failure, and retinopathy. Diabetic neuropathy, or nephropathy, I should say, is now the leading cause of end-stage renal disease. And diabetes mellitus is also the leading cause of acquired blindness in the United States. Again, this is why it's important we follow guidelines and recommendations for screening in patients with diabetes mellitus. Diabetes type 1, let's look at the epidemiology and the causes. So again, we have about 1.25 million people in the US with diabetes type 1, and 10% of all the cases of diabetes, 1.5 to 2 times more common in whites. 60% of them are under the age of 18 at first presentation, and it's usually diagnosed greater than a year and less than 30 years old. You have a higher incidence in Europeans, and there are 2 forms of diabetes type 1. You have type 1A and type 1B. Type 1A is the immune-mediated diabetes mellitus. 90% of people have this type, which is just an autoimmune destruction of the beta cells, usually what is referred to when identified as type 1 diabetes. So again, there's 2 types, type 1A, 1B. When you're talking about diabetes type 1, you're usually referring to type 1A because that's 90% of the cases. There is type 1B. It's considered idiopathic diabetes mellitus because there is no known cause and it has no evidence of autoimmunity. It's basically inherited, so the need for insulin replacement therapy is variable. Okay, in diabetes type 1, there is a severe insulin deficiency. We have beta cell destruction with lack of insulin, which alters fat, protein, and carbohydrate metabolism, resulting in hyperglycemia. In this deficiency, the body uses fats for fuel, releasing ketones. And most patients, keep in mind, with this type of diabetes are diagnosed when they're juveniles. The new onset type 1 diabetes mellitus often presents in crisis and requires hospitalization. Of course, we know the life-threatening sequelae of hyperglycemia, which includes diabetic ketoacidosis and hyperosmolar hyperglycemic syndrome, HHS. Okay, the diabetes type 1 pathophysiology it has a genetic predisposition. It has islet-specific antibodies identified in 70 to 80% of the pre-diabetic and newly diagnosed type 1 diabetic patients. There's an autoimmune destruction of insulin-producing pancreatic beta islet cells triggered by pathogens, which could be foods. And there is cytokinin, which is inflammation, which is usually present. It is a reversible component. And then, of course, hyperglycemia develops once 80 to 90% of a patient's beta cells have been destroyed. So the impact of dietary influences and triggers on type 1 diabetes. Protein component of cow's milk, including bovine serum albumin and beta-casein, trigger autoimmune response. The timing of gluten and rice-containing cereals in infant diet has been implicated in increasing the diabetes mellitus risk. So this is when the child is introduced at less than three months, or greater than 3 months, or less than 7 months of age. No, I'm sorry, less than and then greater than. Education of new mothers is important on age of introduction. So you have to be really careful in terms of introducing cow's milk as well as gluten and rice containing cereals. So what are the signs and symptoms of diabetes mellitus? Polyuria. This is a basic review, guys. Polyuria, polydipsia, polyphagia. We have an increase in urination, increase in thirst, and an increase in hunger. Other things you start to see is a weight loss, fatigue, an increase in frequency of infections. They become insulin dependent, and the peak incidence is from 10 to 15 years. Okay, what is our clinical presentation of type 1 diabetes? So again, the classic subjective symptoms are polyuria, polyphagia, polydipsia. Other things would include anorexia and weight loss. Additional things you'll start to see is nocturnal enuresis, visual changes, weakness, fatigue, nausea, and abdominal pain. You'll get repeated or rare infections, including hyperglycemia, decreased humoral immunity and leukocyte function, and decreased wound healing. Objectively, you're going to start to see weight loss despite normal or increased appetite. You're going to see a reduced muscle mass, signs of dehydration like poor skin turgor and dry mucous membranes. Neurologically, you'd start to see some diabetic retinopathy with visual changes, and the third, cranial nerve palsy, or sixth and fourth. Cranial nerves can also be affected in the cranial neuropathy. Initial testing includes an A1C of 6.5% or higher, a random glucose of greater than 200 plus symptoms of diabetes, including polyuria, polydipsia, weight loss, a fasting plasma glucose level of greater than 126 following 8 hours of no calorie intake. And you want to try to repeat that test just to verify the above. And then you want to do a 2-hour plasma glucose level of 200 or higher during an oral glucose tolerance test with a 75-gram glucose load. Okay, so differentials in diagnostics when it comes to diabetes type 1. So other things to consider in terms of symptoms, presenting symptoms, you could consider in your differential diagnoses, Cushing's disease, pheochromocytoma, or acromegaly. You may want to consider what's going on with the patient in terms of their lifestyle. Do they have any extreme stress or trauma that they've recently encountered? Any renal tubular disease? And are they on any medications like glucocorticoids, sympathomimetic agents, and niacin? Other diagnostics you definitely want to include are a fasting lipid profile, urinalysis, thyroid function tests, and a metabolic panel. You also want to look at urine cultures and a 12-lead EKG to rule out some other autoimmune diseases like vitamin B12 deficiency, celiac disease, hypothyroidism, hyperthyroidism, of course, should all be considered. Make sure you don't get locked in. You always want to consider your differentials. And you're going to also look at all these differential diagnostics to really pinpoint and confirm your diagnosis. Okay, diabetic mellitus pearls, reducing complication in diabetes type 1. The risk of developing complications of type 1 diabetes include retinopathy, nephropathy, neuropathy, which can significantly be reduced about 50 to 75% when A1C levels are maintained below 7%. So education, obviously, and good management is key to doing this to prevent these complications. Elderly with CAD have a slightly less stringent glycemic control to prevent hypoglycemic events. So look at this chart and how I want you to really consider how your A1C percentile correlates with the blood glucose to the right. So in order for somebody to maintain below 7%, they really have to be, maintaining between 130 and 170 in terms of their daily glucose. Okay, diabetes type 1 management. You want to always follow the guidelines of the American Diabetes Association and stress that it is a team approach with your patient. They need to be following up with all of their team members to maintain their diabetes, especially if they're brittle diabetics. And in terms of team, we're talking the endocrinologist, the primary care provider, if that is you, or the physician, the endocrinologist, the podiatrist, okay, the ophthalmologist for the eyes. Again, it is a team effort to prevent acute and chronic complications. Remember, it is a complex and lifelong management, so you're going to want to always continue to encourage your patient, give them a lot of support, give them resources to help give them that support that they may need to continue always managing it. They are going to feel like this is almost like a full-time job. And essentially it is. In order to prevent the complications that come with diabetes, it really does become a daily management. So their treatment program requires insulin regimens, frequent self-monitoring of their blood glucose, medical nutrition therapy, regular exercise, continuing education in the prevention and treatment of complications, and periodic assessment of treatment goals. The initial goal you want to remember is to normalize their elevated blood glucose level with intensive insulin regimens to achieve the following goals. So we want to maintain a plasma glucose level of 80 to 130 before meals. We want to have a peak postprandial or a blood sugar 1 to 2 hours after the beginning of a meal of less than 180. Okay, and an A1C of less than 7% for adults with diabetes type 1. New onset type 1 diabetes often presents in crisis and requires hospitalization. Besides stabilizing the blood sugar, initiating insulin, besides just stabilizing the blood sugar, initiating insulin, you need to treat the underlying problems such as DKA or infections. And of course, follow the recommended routine management, which is right here on this table. So this is your basic outpatient assessment and management guide. So every visit, you're going to be assessing for symptoms of hypo or hyperglycemia. You're going to be reviewing blood results. You're going to talk about problems with adherence, symptoms of complications, any other medical illnesses going on that they're being treated for, any changes in their medications, including over-the-counter stuff that they've included into their diet. You really want to make sure you're reviewing any supplements they're taking. People do a lot of reading on Google and start to try to self-treat. You just want to make sure you're reviewing everything they're taking. You want to obviously reevaluate at every visit their height and weight to make sure you have an accurate updated BMI, as well as their blood pressure, doing a thorough cardiovascular assessment and thyroid exam. Extremely important to follow up with their ophthalmic exam. Make sure that they are following up with their ophthalmologist regularly. You want to do a peripheral vascular assessment, check their feet. Very important for diabetics. And every time you check their feet, you want to re-educate them as patients on the importance of their own self-checking daily for any changes in their feet, any sores or new cuts. We want to look at their neurological assessment and oral examination. Laboratory monitoring, you need to be on top of the A1C every 3 months during the first year of initiation of insulin therapy and during periods of insulin dosage adjustment. Once they have stabilized with their A1C, you can go down to checking it twice a year if it's stable. And then annually, you can start checking their lipid urinalysis and serum creatinine. You definitely want to make sure you're maintaining their general health maintenance with their basic vaccinations and a lot of patient education, especially anything that has to do with smoking cessation and contraceptive counseling. Okay, facts regarding insulin. Human insulin is preferred for patients newly beginning insulin therapy, especially pregnant women and patients with allergies. The majority of insulin today is chemically identical to human insulin by recombinant DNA technology.
It's 4 o'clock.
Or by chemical modification of pork insulin. Beef and pork insulin are still available though. Remember, insulin is available in rapid, short, intermediate, and long-acting forms. The optimal dosage is highly individualized depending on the site, the depth of injections, the skin temperature, and exercise. Okay, remember the dawn phenomenon. This is something you learned about, I'm sure, in your undergrad, but just as a reminder, it's definitely something that could creep up on your boards. So just make sure you're well aware of how to define this and what the treatment is. So dawn phenomenon is considered early morning hyperglycemia due to a complete absorption of evening insulin dose before the early morning hours, particularly if an intermediate acting insulin like NPH is used. The early morning secretion, growth hormone, and cortisol. So there's an early morning secretion of growth hormone and cortisol causing a need for increase in insulin. If the provider increases the nighttime insulin dose to address early morning hyperglycemia, it may lead to evening hypoglycemia in the absence of an adequate insulin effect in the early morning hours. So in respect to all of this, if you use the NPH, the evening dose should be given later. Alternatively, it may be more efficient to prevent early morning hyperglycemia by switching the regimen from NPH to a longer acting form of insulin, such as Lantus or Levemir. Nocturnal hypoglycemia. If the pre-dinner or intermediate acting insulin dose is too high, or the patient skips dinner and they get an inadequate food intake, The patient may not awaken with symptoms, but on arising, may note an increased fasting glucose level. This is a compensatory mechanism in the liver, which responds by mobilizing glucose from hepatic glycogen stores in response to sustained hypoglycemia. So we have the Somogyi effect, which is a unique combination where the diabetic develops hypoglycemia during the night with rebound hyperglycemia in the morning, which is usually observed in children with type 1 diabetes. So self-monitoring and continuous glucose monitoring. SMBG recommend for type 1 diabetes to evaluate effectiveness of insulin regimen, medical nutrition therapy, and exercise. The most practical means to maintain glucose levels as close to normal and to prevent complications, the most common complication of diabetes therapy is hypoglycemia. So again, let me repeat that. The most practical means to maintain glucose levels as close to normal and to prevent the most common complication of diabetes mellitus therapy, which is hypoglycemia. So hypoglycemia is our most common complication. So this is why it's so important that we make sure to educate our patients on how to self-glucose monitor and make sure they understand that the device measures interstitial glucose concentration and can be utilized with intensive insulin therapy, obviously. It is the most widely used and recognized by most insurance companies. And you want to make sure that the monitor you're ordering for your patient is covered by your patient's insurance company. Studies verify they reduce the amount of time type 1 diabetic patients experience hyper and hypoglycemic episodes. And just keep in mind, they do require calibration to work. Okay, so in terms of glucometers, as we were just talking about, they do require sometimes they need to be calibrated. You want to make sure you're instructing your patient on the use. All of them are pretty similar, but every one of them is different. So you want to just make sure you go over it with the patient in your office if possible. That way they can demonstrate that they do know how to use it appropriately. Some of them are now Bluetooth enabled. They download to the computer, upload to your phone. The most important thing is the patient is keeping the log and can understand that how their blood sugars correlate with their nutritional choices. Some of these patients also may benefit from a diet log in the beginning, especially when you're actually working on educating and modifying their nutritional choices. So keep that in mind in the beginning. A diet log as well as a blood glucose log may be required. In its table 58.1, there's going to give you more details on insulin types and recommendations. But remember, in terms of prescribing your insulin therapy, your goals before meals in terms of a fasting blood glucose should range between 80 to 120. Postprandial, or within 1 to 2 hours after eating, it should be less than 180. And at bedtime, you want 100 to 140. That's pre-meal. Okay, hypoglycemia. So remember, this is the most common issue with diabetes. And let's just talk about why it's common and how it's dangerous. So pure glucose is the treatment of choice for hypoglycemia, and patients should keep them handy at all time. They're these little glucose tablets. They almost look like they come in a roll, like a lifesaver roll, but they're bigger and wider, and you can just stick it in the patient's mouth, and it's just literally like a shot of sugar. But you can use any carbohydrate that increases blood glucose level at that time if you need to. You want to avoid foods with significant fat content because it actually can delay the glycemic response. Examples of glucose that would be quick and handy would be 1/2 a cup of any fruit juice with no additional sugar added, 6 ounces of regular soda, and we're talking about regular soda like nothing with diet or sugarless, 1 cup of milk or glucose tablets, and candy other than chocolate can be used in dire situations, but it's not recommended if you have other sources that are actually available. In terms of management, you want to identify, that the hypoglycemia, that the glucose is administered. Then you want to check the blood glucose 15 minutes after the treatment, and an additional carbohydrate should be given if the blood glucose remains less than 70 micrograms. In severe hypoglycemia, in unconscious or unable to swallow, you're going to administer 1 milligram of glucagon subcutaneously to mobilize hepatic glucose stores. In the inpatient setting, you would administer 50 mLs of a 50% dextrose solution IV. Diet facts. So in terms of your diet goals, we want to support a glycemic control. Obviously, we want to prevent hypoglycemia. We want to maintain normal serum lipid levels, attain or maintain a reasonable body weight, promote healthy eating practices, facilitate blood pressure, lipid goals, and delay or prevent the complications of diabetes. Meal plans based on the patient's food choices, exercise habits, medical history, current and goal weight, and lifestyle, cultural, ethnic, and financial factors. So, that's a beautifully put way of how we want to plan our meals around the patient. But that's a lot of factors to involve in a meal plan. So again, your patient may have to decide that based on what's going on with their weight, their food choices, culturally, ethnically, they may not be in the best interest of the patient. So those actually may need to change at some level. And that's something you may want to consider when you're actually making these meal plans. A lot of cultures include a lot of rice, carbohydrates into their meal plans. And that's something that your patient may actually really need to cut out from their meal plan. So these are things you actually need to consider when you're creating a meal plan for your patient. Most patients will benefit from a referral to a certified diabetic educator for a group program or individual counseling. So therefore, also a referral to a dietitian for an initial consultation should be ordered for all diabetic patients at minimum. Okay, so in terms of determining the number of calories to maintain current weight, there are formulas to use. You could use this particular formula for men and women: 66 plus 13.7 weight in kilograms plus 5 in terms of height in centimeters minus 6.8 times the age. That's how you're going to make sure you figure out the appropriate amount of calories your particular patient should be getting per day. You want to definitely stress that they should be eating at consistent times and synchronize it with their insulin therapy. The diet should take into account a higher prevalence of atherosclerosis. And the ADA recognizes individual dietary needs, endorses variety eating plans, including the Mediterranean diet, dietary approaches to stop hypertension, and plant-based diets to meet goals of a healthy body weight, support glycemic control, facilitate blood pressure and lipid goals, and delay or prevent complications of diabetes. So it's really helpful to know that, just keep in mind, the American Diabetes Association definitely has a lot of resources and evidence-based goals and diets for these particular patients. So it's not like you have to, really try to create something new for them. It all exists. You just have to go to the resources. Dietary consideration. So again, you want to know the resources in your area. Utilize those resources on the American Diabetes Association website, especially if you're in any kind of rural areas where you don't have a lot of access to these classes or group therapy sessions. But a lot of hospitals do offer, or medical practices offer, regular classes for diabetics on all aspects of care, especially diet. You want to include, you want to consider for these patients artificial sweeteners or other types of sweeteners like nutritive, which is similar to sucrose. But just educate your patients that they may have a laxative effect. And then non-nutritive sweeteners, which have no effect on sugar, do offer other questionable health concerns in terms of like your fake sugar. There are research that has shown that in lab rats, those types of artificial sweeteners definitely produce cancer in lab rats. So there is definitely research out there that questions the concerns of health of those types of supplements. You definitely want to make sure they're getting enough fiber. And most people in general do not get an adequate amount of fiber per day. The ADA or FDA recommends 20 to 35 grams per day. Most people don't get that, but in diabetics, and especially people who are trying to lose weight, you want to just make sure that they're getting that amount of fiber, because it does help them feel full and stay full longer and faster. Obviously, with alcohol, you want to educate them to use that with caution. It may cause hypoglycemia, and it does include calories, which can affect weight. In terms of exercise, you want to evaluate all diabetics and their current exercise regime. You want to talk about their medical history, assess for any kind of cardiovascular risk factors like hypertension, hyperlipidemia, family history, etc., before developing a regular exercise program. If they have a high-risk cardiovascular disease, you want to refer to a cardiology for exercise clearance prior to getting them involved with that. In the absence of other risk factors, diabetics can perform all levels of exercise and physical activity as long as glycemic control is established and there is no evidence of complications that would preclude the exercise. Okay, so keep in mind in terms of exercise in regards to diabetic patients, exercise can actually exacerbate hyperglycemia if the diabetic patient has too little insulin available. Conversely, if too much insulin is present, hypoglycemia can occur. So make sure that the diabetic patient uses the following guidelines regarding exercise to regulate their glycemic response and make sure they don't jump into hyper or hypoglycemic episodes. So the exercise program should be individualized on terms of activity interest, lifestyle, physical condition, and motivation. It should include at least 150 minutes per week of moderate intensity aerobic activity, and muscle strengthening exercises can also be added. So before the exercise, we want to check the blood glucose before and every 30 to 60 minutes during and after exercise. So they need to check their sugar before, and then 30 minutes into it, and then 60 minutes into it, and then after their exercise. We want to avoid the exercise if the fasting glucose is more than 250 and ketosis is present, or if the glucose level is more than 300, regardless of whether ketosis is present. So if their fasting sugar is more than 250, they should hold off on the exercise. You want to consume additional carbohydrates if the glucose is less than 100 milligrams and as needed to avoid hypoglycemia. We want to identify if there's any changes in the insulin dose or food intake as necessary. Okay, so in terms of urine ketone testing, we always want to recommend that the patient checks their urine for ketones. If they're under any kind of stress or there's any hyperglycemia episodes, we want to identify that early, like to make sure, see if there's ketones in the urine early before we lead to, end up having a severe complication. If the patient is prone to ketosis or has a history of ketotic events, that's when we want to encourage your ketone testing. And we definitely want to check if they're pregnant because increases the stress on the body. Follow-up. So initially we see these particular patients very frequently with a lot of telephone calls, telehealth, until the blood glucose is established and the patient feels comfortable managing the sugar and knowing when they need to really call. Once the A1C is less than 7% and it's regulated and the insulin regimens are stabilized, you can taper off seeing that patient every 3 months. We want to include the discussion of SMBG results, the patient adjustments to therapy, symptoms of DM, complications, adherence issues with treatment plans, changes in lifestyle behaviors, any medication modification, frequency, cause, and severity of hypo or hyperglycemia. We want to make sure they're seeing their endocrinologist routinely, they have ophthalmology for regular dilated exams, that they're seeing their dentist, their cardiologist, their podiatrist, and anything else depending on what's going on with the patient and their complications. In terms of the cardiologist, cardiovascular disease is very closely associated with diabetes mellitus. So it's very common that most diabetics eventually have a cardiologist. What are the ADA recommendations? Again, you need to keep up to date with these ADA recommendations. They do change periodically based on EBP practice. So the ADA recommends in terms of retinopathy that the ophthalmologist or optometrist does a dilated comprehensive eye exam within the first 5 years of diagnosis, which is often inquired at the annual exam if the patient is compliant with that exam. So if there's no retinopathy at the first evaluation, the patient can return every 2 years. If retinopathy is detected, a full eye exam should be done by an ophthalmologist or optometrist at least annually. And then you want to inquire every time you do a physical at their annual physical exam that the patient has seen the ophthalmologist, and you want to be documenting that. You want to watch the guidelines, especially for the older adult or anybody with comorbidities, and how the eye exam recommendations are recommended annually. okay? Because it's so important that you encourage it, and the guidelines dictate whether or not the insurance will cover these exams. So that's why it's important to know the guidelines, because if the patient is entitled to have these exams because of their risk factors, you want to make sure they're getting them, especially if it helps prevent long-term complications. In hyperlipidemia, adults should annually complete a fasting lipid profile due to the increased risk for CAD, and it's usually ordered at their annual exam. So remember, on their yearly physicals, on your patients that you're doing your yearly physicals on, you want to know these ADA recommendations specifically for your diabetics, so that you can make sure to order all the right preliminary exams. Okay, so for nephropathy, the ADA recommends that we assess the urinary albumin for nephropathy at least once a year. You want to screen with a spot urinary albumin to creatinine ratio, and an estimated glomerular filtration rate should be done after a disease duration of 5 years or sooner if the patient has hypertension. Persistent albuminuria, which is greater than 30 milligrams per gram of creatinine, is usually in the earliest stage of diabetic nephropathy, and it converts over to greater than 300. So creatinine will develop over a period of 10 to 15 years in approximately 80% of patients with microalbuminuria, many of whom will also present with hypertension. So the ACE1 value in diabetes mellitus. So ACE inhibitors postpone the progression of microalbuminuria and ultimately nephropathy. We always recommend ACE inhibitors, and it's recommended as initial therapy for diabetic patients with nephropathy. It is contraindicated in women who are pregnant, so you want to be very careful about using it in women who of childbearing age, and before you prescribe it, you make sure to do pregnancy tests on them. ACE inhibitors may also exacerbate hyperkalemia in patients with advanced renal insufficiency or hyporeninemic hypoaldosteronism. Older adults with advanced renal disease and patients with renal artery stenosis may experience a decline in renal function with ACE inhibitors. And if a patient does not tolerate the use of ACE inhibitors, angiotensin receptor blockers, or ARBs, can be used. Some studies suggest these agents can be used together in diabetic patients with nephropathy because they act by different mechanisms. Okay, complications, screening, and management. So we have complications in diabetes. Usually one of the major ones is hypertension. So hypertension in diabetes often includes a manifestation of nephropathy. So controlling the hypertension reduces the rate of progression of nephropathy and also reduces the complications of coronary vascular disease or cardiovascular disease. So the ADA recommends that non-pregnant adults maintain a blood pressure of less than 140 over 90, of less than 90. So they want a systolic of less than 140 and the diastolic of less than 90. Patients with a high risk of cardiovascular disease, 130 to 80, if this can be achieved without significant side effects. The closer the patients approach the target blood pressure, the less likely they are to develop a cardiac sequelae. Initial treatment of hypertension in diabetics includes lifestyle management, and if medication is required, an ACE inhibitor or an angiotensin blocker should be started unless contraindicated. So these are in your diabetics. Remember, if a medication is required, the first one you're going to want to choose for your diabetics and with hypertension is an ACE inhibitor or an ARB, unless it's contraindicated. Patients with CHF and abnormal ejection fraction should obviously be immediately referred for a cardiology consult. Honestly, if you're dealing with a diabetic who's got hypertension, you want to get that patient already referred to cardiology, because the likelihood is, I know around where I am, getting an actual cardiac consult is going to take time, especially for that first visit. You may schedule it and they may not even get seen for another 3 months. So go ahead and get those appointments scheduled just in case, to be a little proactive. In terms of macrovascular disease, it puts the patient at very high risk for strokes, pulmonary vascular disease, coronary artery disease, and other forms of cardiovascular disease. So if they have a lot of uncontrolled angina, carotid bruits, and EKG abnormalities, obviously we may require advanced intervention. Daily aspirin reduces cardiovascular events in patients with diabetes, and patients with disabling claudication or non-healing ulcers require vascular consultation for their pulmonary vascular disease. You want to screen for these diseases because the symptoms may not be present until late in the course of the disease process. So in terms of complications, in terms of neuropathy, 50% of patients with hyperglycemia extending over 15 years will develop some degree of neuropathy. Foot ulcers and related problems due to a decreased peripheral sensation with significant neuropathy are a major cause of morbidity in diabetes mellitus, with potentially life-threatening consequences if infection spreads systemically. Peripheral neuropathy may result in pain, loss of sensation, and muscle weakness. Feet and ankles are the most common, and they're also seen in the knees and upper extremities. Severe pain from neuropathy can lead to sleep and mood disturbances, and annual follow-up foot examinations are indicated in asymptomatic patients. So monofilament should be used to assess sensation at least annually. Abnormal findings with a monofilament indicate need for thorough vascular, neurological, musculoskeletal, and soft tissue evaluation. The treatment usually is a combination of non-opioid analgesics, calcium channel blockers, narcotic analgesics, tricyclic antidepressant, antiarrhythmics, and local anesthetics are frequently prescribed. Lyrica is pretty common. Cymbalta is as well. Sometimes you'll see obviously Neurontin, Effexor, Tegretol, Ultram, and topical capsaicin. Patients with chronic pain syndromes may benefit from referral to a chronic pain clinic. Neuropathy is extremely painful. You really want to get that pain under control. It may not go down to a 0, but it certainly can get pulled down with the right medication combination. But you really need to make sure that that is under control, because that will have a significant impact on the patient's quality of life. So you want to get that under control so that they are able to focus and manage on their actual diabetes. You want to make sure we're referring to podiatrists, because nail and callus care are very important in order to prevent ulcers from beginning at the site of a callus. You want to make sure the patient is wearing good fitting shoes, supportive athletic shoes for walking. Extra depth shoes and custom molded shoe inserts are indicated for high risk foot ulcers. Patients at high risk include neuropathy, structural deformities of the feet, skin, or nails, and those with a history of previous ulcers. Charcot foot disorders usually occur in about 9% of patients with neuropathy, which may be confused with those of cellulitis. It's highly morbidity leads to bone destruction, joint subluxation, and bony remodeling of the foot. Patients with abnormal findings on radiologic exam should be referred to an orthopedist for further evaluation. So foot exams and neuropathy. So you want to check your patient's feet at every visit. You want to really encourage and make sure that patient has a podiatrist. You want to evaluate for neuropathy with a tuning fork and monofilaments. Lots of them are available. They are disposable. You know, things like cotton could also work if you really are in a pinch, but you want something that will really help you pinpoint if the patient is having a loss of sensation. Your patient will definitely probably be experiencing numbness, burning type paresthesias. You want to make sure you're documenting that. Danger is a loss of sensation. So being unable to feel discomfort of infections or injuries, risk for falls, and driving. Keep in mind, these patients are driving. If they can't feel the sensation of the pedal at their foot, this is a problem. So if they have an abnormal sensation, you want to make sure they're following up with podiatry, neurology. You want to treat them with pain medications, TCA, gabapentin, or Lyrica, and other types of medications to help manage the pain. Here's your Charcot foot. It's a serious inflammatory condition that could lead to amputation. There's definitely underlying neuropathy that it begins with. The patient develops bone, joint, or soft tissue deformities of the foot and ankle. And x-rays of the feet are the primary diagnostic indicator. An MRI can also confirm. You definitely want to refer and collaborate with podiatry and have a surgical consultation. Okay, so your foot ulcers. You want to teach your patient to check their feet daily and follow up for any breaks in the skin. They should inspect their feet daily for calluses, blisters, cuts, burns, and ingrown toenails. These minor injuries can develop into severe foot ulcers that could become infected and lead to lifelong issues, including the most severe, which is amputation. Wounds require early treatment, debridement, culture insensitivity, oral antibiotics, and wound care. The worsening of this can lead to osteomyelitis and then, of course, amputation. So I can't help but stress this enough how important it is for follow-up with this. And I will tell you, recently I've had a couple of patients on hospice who have foot ulcers that are worsening and worsening. And unfortunately, because of that, the likelihood is they will require amputation. But when they're on hospice, the goal is to not necessarily get the wound to heal. Obviously, that's what your ultimate goal is, that you want. But in terms of a patient who's just naturally declining, and you're allowing that to naturally happen through the hospice process, one of the things that we just really reinforce is that in the process of managing these wounds, our ultimate goal for them is to keep the wound stable, clean, and prevent them from getting worse or infected, and then obviously prevent an amputation prior to the patient passing. So, it's not always, obviously the goal is always you want to help heal the wounds or prevent the wounds and then heal them. But in terms of where the patient is at, in terms of palliative care, those are the things you also want to consider, is just, preventing infection, preventing it from worsening, and preventing an amputation. Complications, screening, and management. So in terms of pregnancy, obviously these patients are risk for preeclampsia, preterm delivery, intrauterine fetal demise, cardiac and renal malformations. You want to treat them with preconception counseling and frequent follow-up to stress the importance of extremely tight glucose control. Diabetes distress is, something patients experience because of the constant demands of medication dosing, monitoring of blood glucose, food tracking, and increased attention to physical activity, which have an adverse psychological impact on up to 45% of patients. So yeah, diabetes distress, that's a really fancy way of saying like it's really stressful having to manage diabetes. Like I said before, it's almost like having a full-time job, especially in the beginning when you have to really start getting into new habits of just constant monitoring and constant self-evaluation of, your nutrition, your glucose, your activity. Like everything is such an ordeal. So, you definitely want to give a lot of support to these patients. You want to consistently make sure they're doing their annual screening, use of their validated measurement tools, such as the diabetes distress scale for adults with type 1 diabetes. You're just really reevaluating these patients and if they're actually able to cope with the diabetes. And if they're not, that's when you want to refer them to a mental health professional for screening for depression. Other things to consider in terms of complications is autonomic involvement, which can affect GI. They can have some gastroparesis. There are cardiovascular and GU function as well. A lot of times diabetics get issues with sexual dysfunction, and they get, especially in your older geriatric population, we have some issues with erectile dysfunction, and we may need GI, urology, gynecology, and neurology consults, depending on the symptoms. So follow-up and referrals. In terms of the family, you want to refer to an NIH program if necessary, which accepts referrals of relatives of patients with type 1 diabetes for screening with islet cell antibody measurements. They offer treatment with various agents investigated as potentially preventing the development of the disease. So that's an interesting thing to be part of. As many diagnosed as child, the family is highly impacted. The parents need a lot of education, support, awareness of all resources, and again, the benefits from a team approach. You want to definitely look at future models. You want to talk about pediatric growth, development, psychological impact of the disease on the patient and family. Again, the family and the patient may require counseling, supportive community resources, and mental health services. And hopefully these things are available, in your practice, in your area. but not everywhere it is. So just keep in mind that, you may be doing a lot of that as an NP. You may be providing the counseling and giving them those community resources and providing those mental health services. That may fall on your shoulders, if there is nowhere else for these patients to go. Complications. So keep in mind the long-term effects of diabetes literally affects almost every major organ in the body. Diabetic retinopathy is a major complication of diabetes. It is the leading cause of new onset blindness in adults from the ages of 20 to 74. They have studies that show that nearly all patients have some degree of retinopathy at 20 years post-diagnosis type 1 diabetes. They are also very common it's very common to have microaneurysms as well as hemorrhages. There is a growth impairment and increased risk for infection. Autonomic neuropathy may occur, resulting in gastrointestinal, genitourinary, and cardiovascular symptoms, as well as sexual dysfunction. ASCD and PVD and cerebrovascular disease risk factors increase, and the development of life-threatening sequelae of hyperglycemia also is a big risk factor. Diabetic ketoacidosis is more common in type 1 diabetes, and HHS is more common in type 2, and may first be detected at sick visits where they will end up needing emergency care. So the big red flag in diabetes is your DKA, diabetic ketoacidosis. So this is a life-threatening decompensation of glucose metabolism, most commonly in type 1. And remember, your type 1 diabetics are 90% of your diabetic population. So most people who are diabetic type 1 will get this DKA. This is the biggest red flag in diabetes. And the cardinal features of DKA include hyperglycemia, ketonemia, which is a plasma ketone level of greater than 5, and acidosis, which is a plasma bicarbonate level of less than 9, and a hyperglycemia or blood glucose level of greater than 359. And what are the causes of DKA, which would be a lack of insulin, stress, physical or emotional. Even with continued insulin therapy, this can happen, and it precipitates a cascade of events, which eventually ends up causing fat to be used for energy, leading to the release of ketones and acidosis. So the initial signs of DKA include increased thirst, increased urine formation, fatigue, anorexia, nausea and vomiting, and abdominal cramping. Later signs include Kussmaul's respiration, signs of dehydration, oliguria, altered consciousness, which left untreated can lead to a coma, vascular collapse, renal shutdown, and blood glucose increases from 300 to 800. Diagnostics that you want to make sure you're ordering are a metabolic profile, potassium phosphate, bicarb, CBC, osmolarity, ABG, and a calcium anion gap. Beta hydroxybutyrate, you want to make sure you're looking at their blood test and detect beta hydroxybutyrate, a type of ketone indicative of DKA. Appropriate tests for infection if suspected, including urinalysis, chest x-ray, blood cultures, etc. We want to look at our anion gap in DKA, which is the difference between measured cations, sodium and potassium, and measured anions like chloride and HCO3. Blood tests may see a urine gap performed, and you may just see the sodium, but you could also use calculators. You don't just have to follow this particular formula. In this gap, it may be high, normal, or less commonly low. It could be seen in acute care or indicative of multiple disorders impairing electrolyte acid and bases, as well as metabolic acidosis. So a high anion gap acidosis greater than 12 would be ketoacidosis, lactic acidosis, renal failure, and toxic ingestions. A normal anion gap acidosis, which is less than 12, would include gastrointestinal or renal bicarbonate losses and impaired renal excretion. Low is rare, but you'd see albumin and electrolytes. Okay, so there's multiple mnemonics for understanding the causes of an increased anion gap. So you could use Goldmark, Kussmaul, or cat mud piles. So the cat mud piles, obviously here is your carbon monoxide, your cyanide, your A for aminoglycosides, your T for theophylline, your M for methanol, your U for uremia, your D for diabetic ketoacidosis or alcohol ketoacidosis, your P for paraldehyde, your I for isoniazid, your L for lactic acidosis, your E for ethanol, and your S for salicylates. The DKA treatment. So remember, patient is usually sick in the emergency room under acute care. Your aim of treatment is at restoring their acid base and glucose levels, correcting dehydration, treating the underlying cause of infection. You want to administer IV fluids, IV insulin, and anything else that they require in terms of managing them. Obviously, failure to identify and treat DKA could lead to seizures, unconsciousness, and death. So again, in terms of patient education with diabetes, you want to make sure that you're using the expertise of a diabetic educator to help this patient. You want to give them access to community resources, classes, and groups. You want to talk about insulin administration and self-regulation using syringes, jet injectors, pen-like devices, and insulin pump or continuous monitoring. You know, it all depends on your patient, their lifestyle, their education level, their age, and their access to resources. So keep all of those things in mind. You want to make sure they're following up with foot care and managing their feet on a daily basis, self-monitoring. You want to definitely make sure they're on top of their dietary management, making their lifestyle changes appropriately. You want to talk about their care during any sort of acute illness that they need to be managing their diabetes and how it affects it. You want to make sure they're staying up to date with their vaccines, that they're aware of the signs of diabetic ketoacidosis, that they know the importance of glycemic control and the values of preventing complications such as nephropathy, retinopathy, cardiovascular disease, and neuropathy. You want to make sure the diabetic patient is well aware of the signs and symptoms of infection, especially when it comes to any kind of cuts or sores that they may notice develop on their feet. And you want to make sure they're keeping up with their appointments in terms of their annual dilated eye exams, their dental visits, their podiatry visits every 3 months. And of course, to you every so often, depending on how tight their control is on their A1C. Okay, so let's just review everything in summary and how we can apply all of this to practice. Just keep in mind, remember, diabetes mellitus 1 is usually diagnosed in childhood. It is a team approach when you're managing your diabetic patients. They need an endocrinologist. It's so important. The endocrinologist is usually the one who sets up the insulin and monitoring regime. You want to make sure this patient has a diabetic educator in place, a nutritionist, a podiatrist, a dentist, and a cardiologist. You want to make sure that you realize while in primary care, it is our role to make sure that they are maintaining their insulin plan, that we're seeing the patient regularly, often every 3 months, to screen them for complications and to make sure they're managing any issues with their glycemic control. As diabetics typically are considered high risk, you want to stay on top of all recommended primary prevention screenings, including vaccines and screenings to detect complications. So you're doing the urine dip for protein, you're doing their annual eye exam, you're monitoring for cardiovascular complications, you're really making sure you're keeping a tight control and monitoring closely their blood pressure, their lipids, their 12 lead EKG, their foot exams, etc. And you really want to make sure you're up to par every year on the diabetic guidelines, the detailed guidelines for care of diabetics, which is available for type 1 and type 2 in the American Diabetes Association guidelines. And that is what we follow. Okay, diabetes type 2. So diabetes type 2 is an abnormal secretion of insulin, which is a resistance to action of insulin in target tissues and or inadequate response at level of the insulin receptor. It reduces life expectancy due to the complications affected by the duration of the diabetes mellitus, the glycemic control, and the cardiovascular risk factors such as smoking and hypertension. Diabetes type 2 is usually managed by primary care with endocrinology support. Primary care often detects through lab work and discusses and initiates the beginning of lifestyle changes and metformin as indicated to start, and then we get them referred over to endocrinology to take it from there. So the epidemiology and causes of diabetes type 2. The prevalence of type 2 diabetes in the United States is 6.6%. It's often asymptomatic in its early stages, and chronic hyperglycemia is associated with long-term damage and dysfunction of various organs. So the risk factors include a first-degree relative with type 2 diabetes. Your risk factors increase with age. If you have any history of gestational diabetes, it puts you at higher risk. And pharmacological agents associated with iatrogenic hyperglycemia include glucocorticoids, hormonal therapies, immunosuppressants, nicotinic acid, protease inhibitors, atypical antipsychotic agents, and antihypertensive. There is a linkage between CAD, hyperlipidemia, obesity, and diabetes mellitus. The diagnosis of type 2 diabetes in childhood is often and most likely due to obesity. So what are your risk factors for type 2 diabetes? 9.4% of the US population, or 28 million of the US population, are unaware that they have this. Again, when in the early stages of diabetes type 2, it's often asymptomatic. Chronic hyperglycemia is often associated with long-term damage and dysfunction of various organs. There's definitely a stronger genetic association than type 1. At least 40%, at least one affected parent, and monozygotic twin studies have demonstrated between 60 and 90% concordance. Disproportionately impacts ethnic minorities, so African Americans, Latinos, Native Americans, Asian Americans, and Pacific Islanders have a higher risk, and there's definitely the highest risk in Native Americans and Alaskan Natives. So what is the FNP's role in screening for diabetes? What is our role in this whole thing? So we need to make sure we know our role, because that's one thing you want to make sure in terms of just maintaining your standards of care. So the FNP's role in screening for diabetes is that we screen for diabetes and pre-diabetes in all overweight or obese patients despite the age. Obesity is a major modifiable risk factor for type 2 diabetes, which affects up to 90% of individuals with the disease. So 90% of patients with type 2 diabetes are obese, meaning if we modify the risk factor of obesity, the likelihood is that we will modify and improve the risk factors for diabetes mellitus. So that is why it is so important to know in your role as an FNP that we are screening for pre-diabetes and diabetes mellitus for all patients overweight or obese despite their age. So knowing your BMI for every patient that walks into your practice is vital. It's just as vital as knowing a blood pressure, a heart rate, and a temperature. Okay, know your patient's BMIs, because remember, 30 or over, we are considered obese. We want to screen all adults greater than 45 years and older, which is usually done as part of an annual exam in terms of blood work. And then we want to repeat a minimum of every 3 year intervals if it's normal. If the patient has any other comorbidities that necessitate more frequent blood work, you want to make sure that they have their flat fasting blood sugar ordered annually. Okay, so screening and diagnosis in diabetes type 2. So a finger stick or a random capillary blood glucose measurement may be taken without regard to the timing of the patient's last meal. So greater than 200 needs confirmation. So there are 4 confirmatory diagnostics for diabetes mellitus. To make sure they are actually confirmed diagnosis of diabetes, you need these 4 things confirmed. So you need to check their A1C, and it needs to be greater than or equal to 6.5. Number 2, you need a random plasma glucose level of 200 in the presence of classic symptoms of hyperglycemia or hyperglycemic crisis, and you need a fasting glucose level of 126 or higher on 2 occasions. You need a 2-hour post-load plasma glucose of greater than 200 with OGTT when you're screening for diabetes during pregnancy. So in absence of unequivocal hyperglycemia, results need to be confirmed by repeat testing on new blood sample without delay, preferably using the same type of test. So subjectively, many patients are asymptomatic, hence the need for routine screening. You definitely want to consider screening the patients that seem to be presenting with recurrent or specific infections. You want to be screening them for diabetes, especially if they're asymptomatic in all the other avenues. Objectively, you want to consider that most patients that are obese tend to have diabetes, so you want to automatically screen your patient if their BMI is showing obesity, or even if they're overweight. If they have any history of dyslipidemia or hypertension or CAD, again, diabetes is very common with these comorbidities, so you want to screen those patients. If they have any issues with abnormal healing, an increased occurrence of infection, especially if candida, if you're getting a patient with a lot of yeast infections, these are patients you definitely want to be screening for diabetes. Whenever you see candida or frequent fungal or yeast infections, you always want to just immediately consider diabetics, as a differential. You'll see in your nursing home patients, especially with skin stuff going on, the majority of your patients with diabetes will definitely tend to have some sort of fungal infection or fungal rash at some point in their care plan or in their treatment issues. So in terms of the exam, in terms of screening, you want to be checking their height and weight, their BMI, like I said, fundoscopic exam, blood pressure, 12-lead EKG, thyroid palpation, full skin exam. You want to assess for acanthosis nigricans. You want to do a comprehensive foot exam to assess for diabetic ulcers. Lab values with diabetics include a lipid profile, thyroid profile, liver function test, metabolic panel, creatinine, EGFR, and a urine dip for proteins. You want to have this done at least annually and as needed. Follow-up labs, and the A1C indicates this. A1C of less than 7% is strong control. And then one of 6.5% significantly decreases the occurrence of complications. At an A1C of less than 6, you want to review medication, lifestyle changes for need to decrease dose of medication, etc. So differential diagnoses and comorbidities. Other things you want to consider besides prediabetes is gestational diabetes, Cushing syndrome, pheochromocytoma, drug-induced hyperglycemia. One of the things you want to keep in mind is that if you prescribe metformin or any other anti-hyperglycemics and they're not responding to it, you definitely want to consider evaluate for the possibility of diabetes type 1. Comorbidities include links between CAD, obesity, hyperlipidemia, type 2 diabetes, and rule it out in all diabetics. Prediabetes is also associated with hypertension, obesity, hyperlipidemia, example, metabolic syndrome, which is a strong predictor of eventual development of diabetes mellitus and CVD. So diabetes type 2 management. Remember, obviously, it is a chronic illness that requires ongoing healthcare and education to prevent acute and chronic conditions. Hold on one sec, guys. I just have to plug my computer in. Okay, so we know that we have to get frequent self-monitoring of the blood glucose. We know we need medical nutritional therapy with reduction in weight indicated. We need use of oral glucose lowering agents and or insulin, regular exercise, continuing education in the prevention and treatment of complications, and of course, periodic assessment of treatment goals. Now, this is something in terms of the periodic assessment of treatment goals, that's something you're continually reviewing at each follow-up assessment visit. Okay, so diabetes type 2 management, lifestyle management includes, of course, nutritional education, treatment of obesity, physical activity, adequate sleep and sleep hygiene practices, evaluating psychosocial status, stress reduction, and smoking cessation. The ADA recommendations includes that all patients receive diabetes self-management education and diabetes self-management support at the time of diagnoses. Local diabetes treatment programs also include demonstrating lower A1C values, lower weight, and improved quality of life. And ADA includes, guidelines include screening for depression, diabetes distress, anxiety, eating disorders, impaired cognitive function at least annually. And of course, there are high risk factors for depression and anxiety that are associated with diabetes mellitus. So just as a side note, guys, when you're seeing patients that are overweight, not even obese quite yet, when you're seeing them, you want to start educating them then that they need to get control of their weight before it erupts into this. Okay, so just please keep that in mind. You want to start this prevention way before it gets to this point if you have access to the patient at that point, because it'll make your job easier, it'll make their life easier, it'll just be better for everybody involved if you go about the proactive way. Thanks, babe. In terms of physical activity, so yes, you want the patient to get into a physical activity regimen so that they can start to lose weight. But the things that you need to realize in terms of diabetics are that exercise can lead to hypoglycemia, particularly on pharmacological therapy or insulin. So if these patients that you're educating are taking insulin or are any pharmacological medication to treat their diabetes, you want to be sure that you educate them on the symptoms of hypoglycemia. So you want to screen them for macro or microvascular complications that may be worsened by exercise, including coronary artery disease, peripheral vascular disease, retinopathy, nephropathy, and peripheral or autonomic neuropathy. And of course, if positive for any of those, you want to refer to the appropriate specialist for appropriate recommendations for exercise. You want to basically just suggest an increase in general movement through ADLs and a decrease in sedentary behavior. So if the patient goes home after their day of work, or they get home by 2:00 in the afternoon and the rest of their evening is spent sitting on the couch watching TV, I think this is the appropriate time for you to mention to them, hey, how about you take an hour away from TV and go for a nice walk. Okay, so exercise is a specific type of physical activity. Again, the recommendation is 150 minutes a week of moderate to intensive physical effort for at least 3 days per week with no more than 2 consecutive days without exercise. A decrease in sedentary behavior is critical, and not sitting for more than 30 minutes at a time is recommended. In older adults, we want to encourage flexibility and balance training 2 to 3 times a week. And older adults show an improved A1C if resistance training is added 2 days per week. Okay, diabetes type 2 management in terms of diet. So we want to talk about a food diary. Again, we mentioned this before earlier in the lecture, that a lot of the times these patients, especially in the beginning when they're first diagnosed and they really don't understand the whole thought process behind the dietary management, you want to get these patients documenting their food intake for a couple of days. Do a food diary, do a food log, so that you can really look at their food and help them understand the correlation between their elevated blood sugars and their high levels of intake of rice that day, or rice, and then they had a bagel for breakfast, and then they had pasta for lunch. These are the kinds of things you have to show them. One thing leads to another. So if you can show them on paper, sometimes that's very helpful. You want to talk about caloric restriction of 500 to 750 calories of the patient's average daily intake. So we're going to be decreasing their caloric intake by about 500 to 750 calories. Keep in mind, 1,000 calories equals a pound. So in terms of restricting their daily caloric restrictions, we're going to slowly start to decrease their daily caloric restrictions so that overall they start to lose weight. This is where it's really helpful to get a nutrition and dietary counseling involved. You want to talk again about a hypocaloric diet, with a decrease in calories, independent of weight loss associated with increase in insulin sensitivity, improved glucose levels. So keep in mind, the ADA really recommends Weight Watchers for patients with diabetes type 2 or any diabetes. They really recommend Weight Watchers as the best weight loss dietary instruction for your patients. So that is a great resource for patients to have access to. The ADA has specific diabetic diets are no longer recommended. Instead, stresses macronutrient distribution individualized for each patient. They want to avoid trans fats, sugars, flour, and sweet beverages. Treatment, is based around immediately on diagnosis and begins with lifestyle therapy with medically assisted obesity treatment. If the glycemic goals are unmet at 3 months later, you want to begin a single agent or dual therapy with oral anti-diabetic agents, depending on whether the A1C is less than or greater than 7.5%, which we usually begin with metformin. If the glycemic goals are unmet in 3 months, we want to initiate triple therapy. If after 3 additional months or at the time of diagnosis, an A1C is greater than 9% and they're symptomatic, that's when we want to add insulin therapy. There are discrepancies between the ADA and the Endocrine Society's guidelines on when to begin dual triple therapy insulin. So you're going to see lots of differences in practice. The idea for some is to be aggressive, as the patient is likely diabetic for years before detecting, which makes them at much higher risk for developing complications. So you want to keep that in mind. Like, how long has this patient been walking around likely pre-diabetic or diabetic and not been treated? Remember, the longer you wait to treat, the higher the risk for the long-term complications, Okay, so metformin or glucophage. The ADA and the AACE recommend metformin first line if there's no contraindications, such as renal disease or abnormal creatinine clearance, acute myocardial infarction, or septicemia. It may be used as a monotherapy, initial dosing of 500 milligram once a day with breakfast or dinner for a week, and then twice a day with breakfast and dinner. May see the initial dosing of 500 milligram twice a day with breakfast or dinner, or you could do 850 milligram once a day for a week. You want to titrate to a max of 2,000 milligrams. Several weeks of therapy may be needed to achieve the maximum effects of a given dose. So adverse reactions with metformin include diarrhea, nausea, anorexia, abdominal discomfort, which usually resolves with a gradual increase of dosage. So it takes a little bit of time, but the side effects tend to wear off. It does cause a decreased vitamin B12 absorption, which may require periodic testing for B12 deficiency, especially if the patient complains of peripheral neuropathy. Okay, just keep that in mind. At the maximum dose, the monthly cost of metformin in US is approximately $4. So that's pretty cheap, which is a good thing. So the cautions you need to take with metformin, because it may cause the B12 deficiency, which can cause peripheral neuropathy, you do not want to ignore any signs of neuropathy. If it's from the B12, it may be reversible if caught early. So we need to have regular screening of lab work to make sure we're not having B12 deficiencies. Adverse GI reactions are actually very common with metformin. Just let the patient what to expect, and then assess and work with the dose before just discontinuing. You want to make sure you have an adequate EGFR. You do not want to use if the EGFR is below 45 mLs. Be very careful for lactic acidosis. There's a risk in liver impairment, alcohol abuse, cardiopulmonary insufficiency. So those are the patients you really want to watch their livers, alcohol abuse, or cardiopulmonary insufficiency. You want to discontinue your metformin 24 to 48 hours before a diagnostic or surgical procedure due to the risk of a decreased kidney function. And you do not want to resume for at least 6 hours after the procedures until the patient is adequately hydrated. If there's any liver impairment, alcohol abuse, or cardiopulmonary insufficiency, you really want to not prescribe this. Other pharmacological therapies for diabetes type 2, we have sulfonylurea, second generation, the thiazolidinonides. We have the DP4 inhibitors, glucagon-like peptide 1 analogs, sodium glucose transport 2 inhibitors, and meglitinides. Second generation sulfonylureas include amylyl, glucotrol, and micronase. We have Actos, Avandia. Things that you need to be careful with these are edema in the legs, fluid retention, any kind of exacerbation of heart failure. So it's definitely contraindicated in class 3 or class 4 heart failure. So be very careful with Actos and Avandia in these. The diptyl peptidase 4 inhibitors includes Tradjenta, Nesina, and Januvia. Januvia is probably one of the most common ones you'll see. And you want to be careful with adverse reactions, which include Stevens-Johnson syndrome, diarrhea, abdominal pain, pancreatitis, and renal failure. We have our glucagon-like peptide 1 analogs, which include Tanzium, Trulicity, Victoza, and Elaticin. Adverse reactions include pancreatitis, nausea, dyspepsia, injection site reactions, and arthralgias. We do not want to use these particular medications in gastroparesis because they can cause a renal impairment. We have sodium glucose transport 2 inhibitors, which include Jardian and Invokana. Adverse reactions include acute renal failure, ketoacidosis, hypotension, urinary or genital fungal infections, and nausea. You're contraindicated in CHF and nephrotoxicity. We have our meglitinides, and that's Starlix and Prandin. And then complications. Let's get into complications, including hypoglycemia and HHS. So retinopathy is definitely a big complication. Diabetes type 2 is the leading cause of acquired blindness in adults 20 to 74 years old. Up to 25% of newly diagnosed patients may present with retinopathy at the time of diagnosis. So this is why it's so important that we need ophthalmology and that annual dilated exam. Hyperlipidemia is also another major complication in diabetes, including, which includes elevated lipids. Some patients may achieve lipid goals with lifestyle management, and some may need pharmacological therapy. You want to use an ACC risk calculator to make sure we're determining their risk factors in terms of CAD and when they need to be starting on lipid statins. Another complication, nephropathy and hypertension. So nephropathy, we want to do a routine spot UACR and an EGFR annually on all diabetics. The ADA recommends screening at the time of diagnosis because it's not really known how long the patient has had the diabetes and has already had the diagnosis. So it's important to do that as well as follow up with annual screening. Allobuminuria is common with diabetes and hypertension. And besides glycemic control, controlling blood pressure is the most effective thing to slow or reduce the risk of diabetic kidney disease. So making sure that these diabetics have tight blood pressure control is very important. Hypertension is part of a syndrome which includes glucose intolerance, insulin resistance, obesity, dyslipidemia, and CAD. 1/3 of patients diagnosed with type 2 diabetes have hypertension. So you control the hypertension and it decreases the rate of progression of nephropathy, which reduces the complications of coronary vascular disease. So it's a win-win-win when you start to really deal with all the different factors that are, or comorbidities and complications that are involved with diabetes. Once you get all of these things start to get under control, the patient's overall health will tend to be much improved. Macrovascular disease. Most patients are at risk for macrovascular complications, including stroke, PPT, and CAD, as well as associated with diabetes. So in these particular patients, a daily aspirin is recommended for cardiac prophylaxis in patients with a 10-year risk of coronary vascular disease of greater than 10% at a dose of 81 to 165 milligrams per day. So at minimum, give them that baby aspirin. You want to screen all diabetic patients for peripheral vascular disease, coronary vascular, cardiovascular, CVA, and CAD, as symptoms may not be present until late in the course of the disease. Patients with disabling claudication or non-healing ulcers require vascular consultation for their pulmonary vascular disease. You want to keep in mind that macrovascular disease, which is a complication of diabetes, is the leading cause of non-traumatic lower extremity amputations due to peripheral vascular disease and peripheral neuropathy. And keep in mind, foot problems may require a podiatrist, orthopedic surgeon, vascular surgeon, or rehabilitation specialist. Neuropathy, you want to just be evaluating that at the time of diagnosis and at least annually. It may result in pain, loss of sensation, muscle weakness, and autonomic involvement can affect the gastrointestinal, cardiovascular, and genitourinary function. So obviously, when you have your pregnant patients, you want to reduce the risk of fetal malformation and maternal and fetal complications, and every pregnancy in a woman with type 2 diabetes should be planned in advance. So obviously that's not always the case, but that's what you always want to advocate for in your patients. Insulin is the first line medication in pregnancy. It requires tight blood glucose control and should be monitored closely by a multidisciplinary team, including the obstetrician and certified nurse midwife. Hypoglycemia. So it's a clinical syndrome of subnormal plasma glucose concentration. It's not just a complication in diabetes mellitus. 1% of the non-diabetic population is also affected. So in adults, that would be hypoglycemia would be considered a blood glucose level of less than 55. In neonatal, hypoglycemia is a level below 30. And clinical hypoglycemia occurs when blood glucose level is low enough to cause signs and or symptoms. So hypoglycemia etiologies or causes. If the patient is fasting, there's a lengthy list of drugs that can cause fasting hypoglycemia. Any kinds of poisoning, any illegal sexual enhancement drugs can cause hypoglycemia. Pancreatic and extrapancreatic tumors, hypopituitarism can cause it, myxedema, glycogen storage diseases, severe malnutrition, septicemia, pregnancy, and renal failure can also cause hypoglycemia. Postprandial hypoglycemia or reactive hypoglycemia can occur because of GI surgery or other GI tract disorders, which affects absorption. Any congenital deficiency of enzymes, any extreme exertion in untrained physical unfit persons can lead to hypoglycemia. Sepsis and or heart failure can also lead to hypoglycemia. And then fastidious or self-induced hypoglycemia, where the patient is caused it themselves. It could be an excessive intake of sulfonylureas or insulin. Obviously, that can cause a rapid drop in sugar. And then a low or non-existent serum C-peptide level confirms that insulin is being injected exogenously. Okay, so signs and symptoms of hypoglycemia include diaphoresis, tachycardia, hunger, shakiness, altered mentation from an inability to concentrate to coma, slurred speech, and a seizure. Signs and symptoms are highly individualized and can vary from mild to severe depending on the patient. If the patient is acutely ill, glucose levels need closer monitoring due to an increased metabolic demands. Now, parenteral insulin may be necessary when oral agents are not tolerated due to nausea and vomiting and impaired oral intake, of course. So hypoglycemia in type 2 diabetes, although the glucose alert value is defined as less than 70, it may occur in patients with type 2 diabetes for a variety of reasons, including excessive exogenous insulin, excessive dosing of oral antidiabetic agents, missed meals or inadequate food intake, excessive exercise, alcohol ingestion, drug interactions, and a decrease in liver or kidney function. When using 2 oral anti-diabetic agents, the potential for hypoglycemic episodes is greater, and the patient and family members should be aware of this. So just keep that in mind, especially when you're first changing the meds on the patient. If you add another oral anti-diabetic, you want to just notify the patient as well as the patient's family members. Sometimes it'll cause a random reaction where the sugar just suddenly drops. Just be aware of that and know what that means and what they have to do. Differential diagnosis included with hypoglycemia include GAD, panic attacks, hyperventilation, pheochromocytoma, drug or alcohol intoxication, TIA, CVA, and psychosis. So the management of hypoglycemia obviously is to normalize the glucose levels, bring them back up to the normal level, find and treat the cause. You want to look at initial management. In acute hypoglycemia, you want to administer 6 to 12 ounces of orange juice or fruit juice without sugar, any kind of juice. Get them some juice immediately. If they don't have juice, give them a cup of milk. Obviously, the best choice would be glucose tablets if they have them. A lot of women carry them in their purse. In acute care settings, as we mentioned before, you want to do an IV bolus of D50. Hypoglycemia may be a medical emergency given the seriousness of the potential sequelae that comes afterwards, including seizures, coma, cardiovascular dysfunction, and death. So patient education definitely you want to include with not only the patient, but the caregiver as well, monitoring the glucose levels before, during, and after exercise, eating at regularly scheduled intervals, and understanding the importance of self-monitoring blood glucose to self-diagnose and early detection, which may prevent severe hypoglycemic reactions. So complications of HHS. So diabetes mellitus type 2 may develop HHS triggered by infection and subsequent untreated hyperglycemia. So usually you're going to see a profound dehydration, serum hypoosmolality, and blood glucose of greater than 600. Usually there's no ketones. Other risk factors include peritoneal dialysis, hemodialysis, tube feedings with high protein formulas, mannitol, phenytoin, corticosteroids, immunosuppressive agents, and diuretics. Emergency acute care includes fluids, IV insulin, and treatments for any kind of infection. There is a high mortality rate that's associated with this. So DKA versus HHS. So DKA is usually type 1, HHS is usually type 2. DKA is hyperglycemia, usually under 800, whereas HHS is also hyperglycemia, but it's even higher. The anion gap is adjusted, and in HHS, it's high osmolality. DKA, you're going to see metabolic acidosis. In HHS, you're not going to usually see any ketones or acidosis. You're going to see a low serum potassium in DKA, and you won't really see that as much in HHS because HHS is usually triggered by infection and illness, although DKA can be as well, and they both can also lead to coma and death. Both treatments are pretty similar in that you're administering fluids, insulin, and you're treating any kind of infection or illness. So here is a chart just really characterizing HHS in terms of the symptoms, where it occurs, precipitating factors, the symptoms you're going to see, lab tests you're going to want to evaluate, and goals and corrections in terms of electrolyte imbalance that you're going to manage. So patient education would include the FNP teaching and reinforcing goals for glycemic control, medication adherence, and the importance of follow-ups and importance of managing and maintaining and changing their lifestyle to really reinforce habits that are going to be more health-oriented. You want to really encourage the use of professional resources, including the American Diabetes Association and Professional Endocrine Society's guidelines. So here in this particular slide, we have a resource here for the AANP resource toolkit, and that'll give you more resources in terms of where you would refer in terms of diabetes. I prefer just to refer you straight to the American Diabetes Association because they keep up to date the most with the resources that are the best evidence-based practice for patient education as well as provider guidelines. So type 2 education, again, this is another really successful little tool to help patients or to help the practitioner just kind of summarize what the goals are in diabetes type 2. And what the diabetes management involves in the team effort in terms of treatment goals. So again, as very similar follow-up as it is in diabetes type 1, type 2, every 3 months, you're assessing glycemic control, any adverse reactions to medications, lifestyle changes, have they really kept up with it? Are they being consistent? You're doing a urine dip for protein, blood pressure, vital signs, and any signs of complications. You want to make sure that they're following up with that ophthalmologist, podiatrist, dentist, and cardiologist, as well as endocrinologist. And that's it, guys. I hope this was helpful. Diabetes is such an intense thing in terms of managing, treating, and preventing that I think it's so important that we actually just had one lecture specifically focused on it. So I hope this was helpful, and I will see you guys soon. Have a great week.